It's with great pleasure that Prostate Calgary welcomes back our guest speaker, Dr. Tarek Bismar. Dr. Bismar earned a medical degree from the University of Damascus and then performed 2 fellowships in surgical and genitourinary pathology at Wayne University and Harvard Medical School. He was an assistant professor at McGill University, and in 2008, he moved out west and became an associate professor at the University of Calgary, Cummings School of Medicine. Dr. Bismar was promoted to full professor in 2015. He's published more than 115 peer-reviewed publications, mostly in prostate cancer biomarkers and genomic signatures, and currently has active collaborations with several national and international investigators. His research focuses mainly on prostate cancer. I thought I first met Tarek in March 2019 at the Step Up Challenge. Turns out, though, we had met indirectly much earlier. In 2008, he signed off on my pathology report after my first biopsy. A Gleason score 3+4, with only 3 cores of 10 presenting, which was about 12% of the core tissues. Little did we know then that our paths would cross so many times since. So it is my honor and great privilege to welcome Dr. Bismar this evening.
Thank you, Brad, for this introduction. Just for disclosure, that the picture that you had is probably about 10 years earlier. So I have more gray hair now, and I'm not sure how long that would last, but we'll see. Anyway, so thank you again for inviting me to speak. It's always a pleasure to present to the group, and hopefully you'll find my presentation somewhat informative, educational, and if you have any questions, I'm happy to answer. You can interrupt me if you have questions, or if you wanna have it at the end, it's okay as you want. So I'm trying to be less of a scientific in terms of talking technical language, and I would like just to give you an overview of what has been happening in my lab and also what we anticipate happening going forward in the next, I guess, 3 to 5 years. Today, I'm gonna advocate for establishing a molecular platform for prostate cancer in Alberta, which would target 2 arms in prostate cancer. One would be the early, intermediate, or low-grade disease for patients who would elect potentially to go on active surveillance. And later on, I'll talk about more of the advanced castrate resistant / neuroendocrine prostate cancer that we hoped also to build a platform to help us out understand why such differentiation happens in prostate cancer post-treatment. So everybody may know about the new cancer center that is projected to open in the next year. So my lab would actually be moving from the health sciences building to the new cancer center on the, I believe it's on the 7th floor, if I'm not mistaken. And we will be close to Alberta Precision Lab, molecular and hematology lab. And so the projected move is to occur February, March of next year. So this is really exciting, and hopefully we'll we'll have more space to do more research, and we'll have more personnel to be involved in carrying out this research. So as I mentioned, my research program now focus in prostate cancer per se. This is the bulk of what I do. Focus on early disease in active surveillance and how can we predict risk of progression. So we want to use tissue, blood, urine-based signatures to help us kind of understand how frequent patients would progress in active surveillance programs. And also, as a subset, we want to investigate also the resistance or response to radiotherapy in the intermediate grade as well. And then in the advanced stage, we want to look at metastatic castrate sensitive, non-metastatic castrate resistant, and metastatic castrate resistant, as well as neuroendocrine differentiation, to try to predict why a subset of patients or tumors, let's say that, would de-differentiate post-hormonal treatment or post-radiotherapy. And rather than the tumor dying, it will de-differentiate and become a neuroendocrine subtype, which known to have really bad outcome and bad prognosis. So the way we want to use our program to develop the signatures, if we want to use digital pathology, so essentially this is the same way as I look at the histological slides of patients to make a diagnosis. We want to utilize digital imaging systems to see if they can actually be more accurate or identify features that I cannot see in my daily sign out or histological examination on the microscope, and add in what is known as artificial intelligence platform or signatures, algorithms, to help us out to add in predictable signatures to histopathology and genomics. So you may be familiar with this picture that I always bring. So those are my two boys, where they're at the same age. They are 2.5 years apart, but this picture or those pictures were taken at the same age for each of them. And you can see probably they have very significant similarity between the two. However, each one has different manner, I guess you could say, or different behavior. So, and so what we want to do is we want to combine molecular and artificial intelligence tools to differentiate two similar looking, in this case, tumors, histologically that I cannot really differentiate. So both would be like Gleason 3+3. And I want to be able to say, okay, which one is going to be behaving in a more aggressive fashion and have more probability of progression versus another tumor with the same histomorphology, where it's not going to actually progress. So we want to start what we would call a precision medicine or precision active surveillance, if we're talking about active surveillance. But we want to do this in a way that is amenable to clinical implementation and be cost efficient. So I'll explain what's the reason behind this. This is a schematic picture. So we have the histopathology evaluations, and then the idea is we want to collaborate efficiently between the different parties in Alberta. So Alberta Precision Labs, Dynalife, University of Calgary, Prostate Cancer Center, and the pharma companies. And we want to enhance the lab out workflow by combining tissue, blood, urine samples to be investigated in new clinical trials to help us identify signatures that can predict disease progression. And we want to standardize training of new staff, getting students into this program to also be part of it. So it will have an educational component. And then enabling new technologies, so genomics, sequencing, digital pathology, artificial intelligence, all that to hopefully gain new insight into improving patient care and being able to actually offer more tailored treatment decisions per individual patients based on their risk of progression. So we started initially a study where we wanted to look at a difference in molecular signatures between similar grade tumors, so Gleason score 6, 3+3, and patients who progressed and had adverse pathological features on their radical prostatectomy versus those that stayed as 3-3 and did not have any adverse pathological features. So when I say adverse pathological features, which means that when we examined their radical prostatectomy, the tumor had a higher Gleason score or had either increased stage, so PT3, or have surgical margin positivity. And what we wanted to do is to see, can we predict based on the genomics, which patient is going to actually develop this adverse pathology on the radical prostatectomy versus not. And the way we did it, we designed a 101 sample cohorts, half of it samples that did not progress, and half are samples that have progressed. And we did multiple gene expression per patient, so multiple samples. So we took between 1 to 4 samples per patient from different areas of the prostate, and we did gene expression profiling to try to understand the difference between within patients and between patients. I was expecting to find, for example, that the more different the genomic signatures within the patient, so between the different foci within the same patient, the more likely that the tumor is going to actually progress because it's a heterogeneous, so there is multiple genes, different genes, etc. But what was interesting is that I found the opposite in the results that we investigated initially. So actually, the more homogeneous or the more similarity between the different foci within the same prostate, the more likely that this tumor is going to actually progress and be showing adverse pathology on the radical prostatectomy versus the cases where you have different genomic signatures between the foci. And I think the reason, or my hypothesis, would be that usually the tumor is more heterogeneous initially, but when you start having more clonal similarity between the different foci, that would signify that the tumor now is ready to actually progress and metastasize. So obviously this is still to be validated, and this is what we want to do. So in collaboration with University of California and Los Angeles, we will look at their samples that they have and do the same study to see if we're going to find the same results. So why it's important to have a low-cost molecular signatures, or whatever signatures we're going to develop, is we don't yet know, for example, especially in patients where they are on active surveillance, so you're not removing the tumor completely, so patients will still have their cancer and you're following them up over time. We don't have yet an idea how you're going to perform the molecular test, for example. would you, based on whatever I presented, that there is a heterogeneity and differences between foci? So how would you construct this test? Would you test one biopsy only, one area, or would you test multiple biopsies and combine the results? And then also how often you should be testing the tumor, because as you know, with time progressing, the genomic background of the tumor may change over time. So we don't have an idea, okay, if you test someone at 0.0, or let's say in January of, I don't know, 2020, in 5 years, the genomic would change, but how often you should be repeating the test to still be able to predict if the tumor is going to progress or not progress. So all of these would require that you have to utilize the test multiple times over time. And of course, if the test is costly, you most likely not going to find much interest from healthcare, for example, to implement those tests, because it's costing them a lot more as compared to just having surgery or having radiation. And we want to do this because we know that specific treatments like surgery or radiation comes with side effects, unwanted side effects. So we want to be able to develop a low-cost test that is clinically achievable to be implemented over time, and it doesn't really affect patients negatively. And one of the reasons, as you know, in active surveillance, if you repeat the biopsies over time, there is a slight risk of bleeding, infection, discomfort from patients. Currently in active surveillance, most of the patients have the same protocol in terms of follow-up. So whether it's like repeat yearly biopsy, repeat yearly PSA, or every 6 months. So what we want to do is to try and develop a test where you have patients coming into active surveillance where they have initially the same histomorphological features, and then you implement a biomarker or imaging or genomics. We don't know yet which platform is going to be the best, or a combination of those platforms. And then being able to say, okay, based on these tests, these patients have higher risk of potential disease progression. So I'm going to now put this patient on closer interval for follow-up, or I may advise them to just seek active therapy rather than actually going into active surveillance, because I know based on the test that I did that the rate of progression is high. So why subject the patient to delayed treatment and repeat biopsies over time if I know that within 3 years maybe I will probably need to seek active treatment? So if I know that upfront, I can just make my decision and have the patient avoid this unnecessary repeat biopsy, etc. On the other hand, if I do my tests and see that the tumor have features of indolent behavior, it doesn't really show any potential rate for progression, then I will offer the patient increased intervals of surveillance. So rather than having a yearly biopsy, then I'm able to say, okay, for the patients, safely come back after 3 years or 5 years, we're just going to do a repeat biopsy or repeat testing, rather than having the patient repeat the biopsies every year to make sure if the tumor has progressed or not. And of course, we will probably have intermediate group where we can say, okay, we're not able yet to say based on the test 100% if it is really low grade or really high grade. So we will watch the patient and ask them to come back every year or every 2 years to repeat the test. And so obviously, if the test is expensive, you're not going to find the healthcare system amenable to actually accept our test to be implemented. on a yearly basis, or every 2 years, or every 3 years. But if the test is cheap, you'll be able to do that and avoid unnecessary biopsies and anxiety on the patients. So we had done several studies based on retrospective samples that we have. So we have samples of various patients. We know the outcome of those patients, and we go and test a specific genes by either protein assessment or by genomic assessment. We try and develop signatures from 2, 3, or 4 markers that can associate with the rate of disease progression. And then we go back and validate those signatures in the low to intermediate grade tumor. So Gleason score 6 and 7, so 3+4 and 3+3, because the bulk of patients within the active surveillance, they're going to be in this range. So we want to see if we're going to be able to tease out some of the potential markers that we plan to implement now on actual active surveillance samples that we have. Again, it's retrospective, and we know the outcome, whether the disease has progressed or not. And then the idea is test those signatures, come up with the best performing panel, maybe it's a 2 or 3 markers, and do this in several steps. So do the digital pathology and add in the other platforms to see which platform is going to be actually able to inform us in a better way about the disease progression rates. So we had here a couple of markers, CRISP3 and PTEN and ERG. In this one, we had done PTEN and ATM. PTEN is a tumor suppressor, and ATM is the same thing. Again, stratifying patients into different risk groups. And then we also have another signature with another markers called TFE3, and then ERG and PTEN. So you can see that, for example, patients with PTEN loss, they have the worst probability of disease progression, and patients with ERG positivity and PTEN negative, they have the best prognosis, and the ones with different combinations, they are in the middle. So what we want to do now is try and look at all the markers that we did in the cohorts that we have, and select candidate markers to now go back in the actual active surveillance samples, test those, and add in the digital pathology, the artificial intelligence, add in sequencing from the tumor, and add in sequencing from blood, and investigate which of those platforms will enable us to really have a tight prediction, an accurate prediction for disease progression. And once we lock in that signature, the idea is now when we get new patients enrolled in active surveillance, then we're gonna offer them the standard of care and also do the actual genomic test or whatever test we identify, and then assess going forward over like 3 to 5 years if our signatures is able to predict the disease progression compared to standard of care, and how often those signatures is going to change, if it is whether it's a digital imaging, whether it's a genomic signature, how often they're going to change over time, so we can try and understand how frequently we have to repeat the test over time for patients to be able to still predict the disease progression. And then hopefully we'll be able to plan guidelines later on to say, okay, based on the signature, this is how often you have to repeat the biopsy, whether it's a 3-year, 5-year, 2 years, or 1 year. So it's still early in the progression stage for figuring out the markers, but I think we put all the platform together, and we are hopeful that we'll be able to figure out something within the next few years. In the advanced stage, we also want to employ molecular biomarkers to help us in predicting patients who will or tumors that will de-differentiate and become neuroendocrine if you give the patients hormonal therapy. So currently, we don't know why some patients or some tumors, rather than dying because of the anti-hormonal or the anti-androgen, the tumor, for some reason, de-differentiate and gain additional genomics features and become a neuroendocrine and progress. So we want to try and understand this. And the way to do it is we also going back to samples that we have of patients that have been treated and de-differentiated to neuroendocrine. And we're trying to do, again, genomics and digital pathology on the samples prior to treatment to see if we can predict based on those who will progress to neuroendocrine differentiation or not. And so as part of the investigation or genomics that we're doing, I also have interest in understanding the genomic backgrounds as it pertains to ethnicity. So I'm originally from the Middle East, so I'm from Syria. And in the Middle East, seems that prostate cancer is not widespread as compared to North America. So we don't know yet why is that. Is it because of diet? Is it because, I mean, we don't exercise that much anyway, but is it because of diet or is it because of the ethnic background? So Middle Eastern versus North American populations. So as part of this, I have interest in getting samples from the Middle East and looking at genomics in those samples and compare the genomic profile as to those of North America. So just initially where we looked at two genes, one is called NKX 3.1, which is a tumor suppressor, and the other one is MYC amplification. And we looked at the two cohorts, one from the Middle East, and we compared this to North America, and we found significant difference. So NKX deletions, which signify aggressive disease, occurred in about 16% of Middle Eastern origin, as compared to 20% in North America. And then the MYC amplification occurred in about 2.5% as compared to 16% in North America. So clearly there are some key differences between tumors in the Middle East and tumors in North America, but we still don't understand fully how to explain the rate of progression or the severity of disease in North America versus Middle East. So that's another aspect in my lab that we are trying to investigate as well. So in conclusion, immunohistochemistry biomarkers may play a role in stratifying patients within the active surveillance into various risk groups. So these are tests that we could run on tissue samples of prostate biopsies, for example, that are run routinely in our practice. And the hope is that we can combine few markers together and test them on prostate biopsies of patients, and then we can accurately predict whether what would be the rate of disease progression in active surveillance. And so we want to do this. We want to also add in artificial intelligence platform using digital pathology, genomics, and see if we can improve the overall predictability of assessing disease progression and also the potential therapeutic response, and allow for morphology/genomic correlation. Obviously, we need to be accounting for ethnicity and should account for that in any genomic signature development. And also on the side, so the Department of Pathology, we are also investing in a digital pathology platform through the University of Calgary, with the hope that we will bring all of these platform together to be tested on samples of patients with active surveillance, and then moving this forward into future clinical trials. So our current studies, we are part of the Marathon of Hope in the Prairie to actively sequence more than 200 advanced and metastatic samples of prostate cancer, renal cancer, and bladder cancer to help uncover the genomic features of cancers associated with therapy-resistant progression across stages and ethnicities. And also, my colleague here, Lin Yang, along with the Prostate Center, we are also planning to conduct prehab/exercise program at PCC to investigate how exercise can improve cancer outcome, and also how exercise actually does change the cancer genome of patients and help us understand what's the importance of exercise and diet and prehab programs to have a better outcome for patients. So finally, I would like to just make you aware that if you are interested in supporting any of the studies that we are currently running, we have and currently actively recruiting patients at various stages of prostate cancer, whether it's metastatic hormone sensitive or castrate resistant, into various genomic studies that we are running. And feel free to, if you're interested, to inquire at the PCC. The two most active urologists are Dr. Gota and Dr. Donnelly, but any urologist would be able to also guide you if you're interested in participating. You can also contact the PCC staff, Erin Mitchell, at the phone number below or the email, or you can also shoot me an email and I'll help guide you in. So most of the studies may require patients to donate blood, urine, and give consent to utilize whatever tissue we have in the pathology department to be able to investigate genomics on those samples and also help develop novel therapies. So we're working on CAR T-cell immunotherapy for prostate cancer, along with renal cell carcinoma. We are working on trying to identify signatures in urine samples and blood to reflect what is being genomically present in the tissue samples, with the help to be able to investigate newer therapies. So if anybody is interested, feel free to contact any of those people. And thank you so much for your interest and attendance, and I'm happy to take any questions.
Thank you, Dr. Bismar. Wow. There's multiple trials. Look at that. Metastatic, hormone sensitive, metastatic, non-metastatic, castrate resistance. There's active surveillance. So you've got a pretty wide field there to cover. This is very exciting, and I know the Prostate Cancer Center just got some funding for some genome testing for metastatic disease. How far away, I'm going to put you on the spot, I know, how far away are we from active surveillance gene testing?
So we can test gene testing in active surveillance, but I think you, if I'm correct, you're referring of genome testing to predict disease progression, if that's what you're referring to. Yeah. So I would say probably between 3 to 5 years, hopefully we'll have some sort of idea which genes would be significant to test. I mean, we have some ideas now, but I think we need to be able to prospectively validate those signatures. So there are a couple of genes we know already that they are associated with disease progression and metastasis, but whether they are of added benefit in the active surveillance to help us out tease those that gonna progress versus not, I would say between 2 to 5 years we should have good grasp on this. There is actually currently even a digital pathology signature that can predict disease progression, or actually can predict hormonal therapy response. One of my colleagues at University of California, San Francisco, did this, but is not being tested in active surveillance. So what we're trying to do now is build similar platform, but we don't want to just do the digital or morphological signatures. We want to do all of those together and then see which one of those or which combination is going to be able to actually help us out.
Very simple. In one of your first slides, I'm familiar with most of the acronyms, but not with NEPCA.
The
Yes.
acronym. Yeah, did you get that?
PCA and E, yes. Prostate cancer. Okay, let me go back. This is the neuroendocrine differentiation. I'm sorry. Yep. So that's the neuroendocrine prostate cancer. So the incidence or the rate of neuroendocrine prostate cancer, if it is de novo. So de novo is like, let's say like if you have 100 sample or 100 patient with prostate cancer that not been treated, so no treatments prior, the rate of neuroendocrine is only about 1%. However, what we are seeing now is that more and more patients in advanced stage, when they are treated with the various anti-hormonal therapy, so enzalutamide, abiraterone, ablutamide, all of those, the rate of neuroendocrine differentiation is becoming higher. So up to 25 to 30% of tumors would actually develop this type of neuroendocrine or this type of histology post-hormonal therapy, because I think the multiple treatments that you have to put patients on, they somehow cause selective pressure on the tumors, and for some reason they differentiate. Now, not all the tumors do this, but a subset do this, and we don't know what are the triggers or what are the molecular changes in those tumors that may predispose patients to develop this type. So this is what we're trying to understand, and that's why we are collecting samples of patients who've been treated multiple times or and develop this neuroendocrine differentiation, and then going back and getting the samples prior to the treatment, and we want to now profile them and sequence them to try to understand, do we see actually any genomic signature that could help us out understand why this differentiation happens.
So if I heard correctly, this is a type of prostate cancer that has not been treated previously?
No, the neuroendocrine, usually it's being treated.
Okay.
So if it is not being treated, it will only occur, or the incidence of this type is very rare. It's just 1% or even less. But when patients being treated multiple times with the different anti-hormonal therapies, the rate increased to like 30%. So 1/3 of those samples or those patients may actually develop this neuroendocrine differentiation, depending on how far they are staying on those treatments and how many treatments of those they actually got. But again, like, we don't know why or who would develop it. So that's what we try to understand.
Yeah, that makes more sense now. With that, we finished exactly on time. It's 8:30, so well done, Tarek. We appreciate that.
Thank you.
We thank you so much for making time for us this evening. We always learn new things, and we look forward to you coming back in 2 to 3 years when, no, we'll have you back before that. But
Before that, yeah, I'm hoping that maybe we'll develop something sooner. So
yeah, that's what we're all hoping too. So we're hoping to have you back when there are new developments. So again, we appreciate your time. So it's so valuable, and it's very generous of you to share it with us. So thank you.
thank you so much for your invitation, and happy to be here and present to the group, and all the best for all of you guys.
Good.
Thank you.
Thank you.
All right, take care.